Dear colleagues, welcome to this ESMO regional talk where we will be discussing much of the interesting science that was presented at ESMO 20 Educational Weekend and the potential implications these sessions can have on our daily practice and our future outlooks. We have the extreme pleasure of having some great colleagues representing 5 countries, and it's an honor to present Dr. Lazar Popovich, Professor of the Oncology Institute of Vojvodina, University of Novi Sad, Dr. Mila Petrova, Department of Medical Oncology, Hospital Nadezhda Sofia, Dr. Pavel Sobchuk, Department of Soft Tissue, Bone Sarcoma and Melanoma, Maria Sklodowska-Curie, National Research Institute of Oncology, Dr. Evgenia Karchenko, Medical Oncologist at the Outpatient Clinic, Petrov National Medical Research Center of Oncology, and Dr. Petra Bukovic, Medical Oncology Resident working at the University Hospital for Tumors in Zagreb. Welcome all to the meeting. The format of the meeting will be a quick presentation by each participant. When each one is done, we will discuss one question regarding the presentation and how it affects practice in everyone's home country. Dr. Popovich will lead us off with his presentation. Dr. Popovich.
Hello, everyone. My name is Lazar Popovich. I am a medical oncologist from Novi Sad, Serbia. And I give you a brief comment on 2 great presentations from Dr. Birtl and Professor Bamias on metastatic urothelial cancer. I will start with Dr. Birtl's presentation. She talked about new position of checkpoint inhibitors in first-line treatment of metastatic urothelial cancer, especially important after 2 negative trials presented at ESMO 2020. It is Keynote 361, pembrolizumab plus chemotherapy versus pembrolizumab monotherapy, which is unfortunately negative trial, and also Danube trial comparing durvalumab versus chemotherapy or durvalumab plus tremelimumab versus chemotherapy. She discussed also previously published trials in Vigor 130 comparing atezolizumab with chemotherapy versus chemotherapy only versus atezolizumab only, showing promising result in only progression-free survival in TETO3 population and promising result in PD-L1 positive population in atezolizumab arm. Probably the most important place of checkpoint inhibitors is in maintenance therapy after response to platinum-based agents, showing in Javelin 100 trial where atezolizumab was compared to placebo after at least stable disease from 4 to 6 cycles of chemotherapy. This is only fully positive trial, but when you look at the design, this is the smartest design of all checkpoint inhibitors trials, showing that good prognosis patients have even better prognosis if we add avelumab in maintenance therapy. Second presentation is from Professor Bamias from Athens. The name of the presentation and the topic of the presentation is what to do if immunotherapy in metastatic urothelial carcinoma fails. He showed the results of enfortumab vedotin trials, showing very promising response rate in phase 2 trial after progression to chemotherapy and after progression to checkpoint inhibitors of 44%. Also, he showed results of erdafitinib trial. It is tyrosine kinase inhibitors in patients with metastatic urothelial cancer with FGFR wild type cancers, showing a response rate of around 45%. And what is the most important, response rate after in 22 patients progressing after checkpoint inhibitors is 59%. What is also very important, from those 22 patients, only 1 responded to checkpoint inhibitors, which probably means that we should test FGFR mutation maybe in all patients before we start second-line treatment after progression to chemotherapy. Also, he showed some results of chemotherapy after progression to immunotherapy, checkpoint inhibitors, which is very important in East Europe, where we don't have erdafitinib for our patients. Thank you very much.
Thank you very much, Dr. Popovich. And now to open up this question to the rest of the panel, I would like to ask, when is the best moment for using CPI in middle-income countries, and what is the best sequence in metastatic urothelial cancer? Dr. Petrova?
Yes, I want first of all to thank Lazar for the really beautiful presentation. Really, the data is very constructive and very positive, but what I'm very unhappy to say is that the cost effectiveness of the therapy is what is going to be a great obstacle for all our countries from Central and Eastern Europe. The situation now in my country, in Bulgaria, is that very few patients with metastatic urothelial cancer actually get access to the pembrolizumab in second line. So in the view of your presentation, I really doubt that in the next 2 years in my country, avelumab as a maintenance therapy would be available for our patients. It's really very negative news, but this is the situation, especially with all these immune checkpoint inhibitors coming straight away in the treatment of different solid tumors. So my concern is that unfortunately in my country, we will not have this treatment in the next 2 or even 3 years.
Thank you, Dr. Petrova. Dr. Vukovic?
The situation in Croatia is a little bit better. So we have access to pembrolizumab and atezolizumab as a monotherapy in a first line for patients who are cisplatin ineligible, PD-L1 positive. And also we have access to pembrolizumab, atezolizumab, and nivolumab as a second line after platinum-based chemotherapy. So the situation is a little bit better compared to Bulgaria. So sequencing is based on what we have given in first line.
Thank you, Dr. Vukovic. Now, following on to our second presentation, Dr. Petrova.
Thanks a lot, and it's really great honor to be with you and to discuss some interesting parts from the ESMO 2020. So what I was very happy to see a poster by the Italian colleagues from Ferrara, Dr. Ferrara and his co-workers, and they continued one problem that we are talking about in the last 5 years. But as you may all know, this is a problem and this is a phenomenon when many authors actually and researchers do think that this is not apart from the immunotherapy treatment only. I'm talking about the hyperprogression. We all know that still we don't have an optimal definition of this phenomenon. We still don't know about its incidence and to what extent it actually might be related only to immunotherapy. What we also know that there are no current biomarkers that could eventually predict the development of this life-threatening condition. A few years ago, actually 2 years ago, Dr. Ferrara had a really nice publication on JAMA about the incidence of hyperprogression in patients with metastatic non-small cell lung cancer in second and third line, and actually showed that patients who were treated with immunotherapy, the incidence of hyperprogression was around 14%, while patients treated with chemotherapy only, the incidence was really low, it was only 5%. At the ESMO 2020, we had a really nice poster. This time, Dr. Ferrara focused on the problem of hyperprogression in patients who received first-line treatment, either with only immunotherapy or combination of immunotherapy and chemotherapy. The group was definitely small, only 94 patients. 44 of them received immunotherapy as first-line treatment for metastatic non-small cell lung cancer. The rest received a combination of chemotherapy and immunotherapy. And his results actually showed that the incidence of hyperprogression in first-line setting was 16%. You all know that worldwide the incidence of hyperprogression is around 4 to 29%. And in this poster, although the patient population was really small, the incidence is around 16%. What Dr. Ferrara showed also was that patients who received hyperprogression had median overall survival around 4 months, and the other patients who didn't show hyperprogression, their median overall survival was 38 months. So you see that the p-value was really, really big. It was a significant trial. What Dr. Ferrara concluded was that in first-line setting, hyperprogression occurs in around 60% of non-small cell lung cancer patients treated with immunotherapy. And in patients who received combination of immunotherapy and chemotherapy, hyperprogression was a rare phenomenon. What I would also like to add was a little Bulgarian experience in this setting. This year we had a publication about the incidence of hyperprogression in Bulgarian patients treated with pembrolizumab in second-line setting for metastatic non-small cell lung cancer. And our results showed that the hyperprogression in Bulgaria in this setting was around 10%. And what we showed that patients who initially, before the immunotherapy treatment, had elevated neutrophil to lymphocyte ratio and low muscle mass, actually they were at higher risk for development to hyperprogression, and also they had lower overall survival. Thank you.
Thank you so much, Dr. Petrova. Opening the question to the rest of the panel, regarding hyperprogressive disease, according to your practice, is this phenomenon immunospecific, and do you see it often in the daily practice? Dr. Sobchuk?
Thank you, Mila, for the great presentation. From my practice, I don't work with the lung cancer patients, but mostly with melanoma and sarcoma, but we also use a lot of immunotherapy. We don't see hyperprogression that often, but that might be also the tumor specific, so it might be more frequent in other tumors, but definitely it's a problem. And I think in everyday practice, we need to decide what should be the frequency of imaging and when we should do the first one to avoid the hyperprogression and decision that patient is progressing and changing the treatment, especially if we don't have too many options for the next lines. In melanoma, this problem is maybe more pronounced in the second line when we treat patients after BRAF/MEK inhibitors, when we don't know whether it's so aggressive disease or hyperprogression. So probably this needs to be more studied also in other cancers, and probably we'll see more with new diseases treated with immunotherapy.
Thank you very much. Moving on to our next presentation, Dr. Sobchuk.
Thank you very much for invitation and ability to join this great discussion. I would like to draw your attention to some other presentations, maybe not so tumor specific, because quite often we think about the ESMO as very scientific meeting that don't affect our everyday practice, especially in our Eastern Europe countries, where the new drugs that were presented will be available probably in 2 or 3 years from now. But there is a lot of educational and useful data, especially considering toxicities and immunotherapy toxicities that we are all the time learning. Even though in melanoma, IO is used for already many years, and probably this is the cancer from which we have the most experience. So we share it also for other tumors. So here at Educational Weekend of ESMO, there was a very interesting presentation by Caroline Robert at the melanoma session, who showed how to deal with the most important toxicities and some new findings, especially about the skin toxicity that now can be used as the prognostic and predictive factor, because patients who develop skin toxicities also tend to have better responses and maybe even better survival, but this data need to be further studied. She also showed her suggestions how to deal with patients who have pre-existing autoimmune diseases, because we see more and more of such patients who require treatment, but from the clinical trials, they were mostly excluded, and we need real-life evidence. And she presented some of such data, how to approach those patients and whether to expect toxicities and what toxicities those can be. And the other session I would like to draw your attention to is the joint session with MASK about new drugs and old drugs and new and old toxicities. which covered many different types of toxicities, neurotoxicity, gastrointestinal, and also skin toxicity, especially that it was presented by the oncodermatologist. So it's a completely different perspective from our oncological perspective, that we usually are not so fluent with dermatology. So many useful guidelines were presented there, so I highly recommend to watch it. But in future, probably we will be discussing toxicities even more, because new combinations of IO and chemotherapy or targeted therapies are approaching. So learning with every year how to deal with IO toxicities and toxicities from other drugs is very important from our perspective, probably. Thank you.
Thank you very much, Dr. Sobczuk. Opening up the question for the panel. With growing evidence on combinations of IO and targeted therapies, chemotherapy, what do you see as the biggest challenge in terms of toxicities? Dr. Petrova?
What for me is a great and a big challenge is in daily life when we see patients with adverse event, for example, grade 3, but when these patients do have a benefit from the immunotherapy. And we all know that in clinical trials, when we are talking about grade 3 or even 4 adverse event, then the immunotherapy should be discontinued in most of the clinical trials. But in routine practice, when we see a clinical benefit for the patient and the patient has experienced such kind of adverse event, for me and for most of my colleagues, it's really very difficult how to proceed. Should we re-challenge the immunotherapy? Should we stop it? So this is what for me is also a huge challenge and a huge question.
Thank you, Dr. Petrova. Dr. Popovich?
Yes, I think we can all agree that usually checkpoint inhibitor treatment is a safe issue, but also there is one sentence that I like to say when I talk about checkpoint inhibitors. Russian roulette is safe, says by 5 from 6 persons. So when we have grade 3 or 4 toxicity, we can have it on any organ in the body. So every oncologist and every doctor should be aware of that.
I absolutely agree. And I think that the most challenging thing is that we need to provide more information to other specialists and, of course, educate our medical oncologists just to keep our experience, etc., and share it as well with other specialists. That's why we have ESMO Educational Weekend.
Exactly. And now with that wonderful message, then we continue to our next talk, which is Dr. Kurchenko.
Today, I'm going to talk about excellent presentation by Dr. Tai, Dr. Viladot, Dr. Pellisgaard, which we all heard on ESMO Educational Weekend. And this topic was dedicated to GI tumors, especially to circulating tumor DNA. So right now, all of us know the important role of circulating tumor DNA. So it's growing day by day and in our clinical practice. So in some centers, we already implement it. And what we know that it's not invasive, real-time diagnostic and predictive tool. And it provides more information about all the lesions and patients potentially that patient potentially have. So as well, evaluating circulating tumor DNA can give us information about some common and some different mutations as well. So in general, clinical implication of circulating tumor DNA are detecting mutations as a biomarker, monitoring tumors, tracking resistance during treatment. And as I mentioned before, during ESMO Educational Weekend, we I've heard absolutely amazing presentation about circulating tumor DNA in colorectal cancer. So it's obvious that it's better dedicated in stage 4 than in stage 1. And what can we say regarding circulating tumor DNA in metastatic colorectal cancer? That we can as well detect mutations like BRAF, NRAS, KRAS, not only in tissue, but as well in plasma. Circulating tumor DNA can provide us information about monitoring tumors. So we know that there were some scientific studies which showed us, let's say, correlation between radiological response and decline of CTDNA. As well, it helps us to tracking resistance during treatment with monoclonal antibodies and to find patients who will potentially benefit from EGFR rechallenge. So as well, it provides a really useful information for us. Do we need to provide adjuvant treatment for colorectal cancer patients or not? We know that 1 in 25 patients will benefit from adjuvant treatment in stage 2 disease, 1 in 5 in stage 3 disease, and it became more clear for us after IDEA trial. So just to conclude everything that I mentioned above, right now, what we know about CTDNA, it can potentially provide us a marker-based strategy. In case of negative CTDNA, we can avoid to prescribe chemotherapy in adjuvant setting. Potentially, it can help us to know the prognostic impact. So positive, very high of recurrence, negative CTDNA, low risk of recurrence. And of course, we need more information, more data on it, but I think that in nearest future, it will help us to treat our patients, let's say, more precisely.
Thank you very much, Dr. Kurchenko. Now opening up the question to the panel. Do you have ctDNA detection in your centers? And is this something that will impact clinical decision-making for your cancer patients?
I can again share my experience from the melanoma work, where establishing whether a patient has a BRAF mutation or not is highly important. And of course, we tend to do it from the tumor, but as melanoma usually is a small lesion and not always we have lymph nodes or easily accessible metastasis. So we sometimes use ctDNA to detect the BRAF mutation, and it's quite useful tool for around 50 patients for which we perform it, mostly due to lack of the material or need to have the fast result. We had around 40% of BRAF mutant patients. So this is quite similar to what we observe from the tumor. So it's a reliable tool. But of course, if we have the negative test, we try to confirm it in a tissue. So definitely it's becoming the clinical practice, but I don't think it's a broad application. For detecting specific mutations, yes, but to monitor the disease, probably not yet.
Thank you very much, Dr. Savchuk. Dr. Petrova?
Yes, I can talk about lung cancer patients, and what I can say that we have the circulating free DNA, especially for patients with the EGFR positive non-small cell lung cancer. We do it when patients, when they are treated with the EGFR TKI, and upon progression, we can use it as a non-invasive biomarker to see if we can proceed with third generation TKI, if it's not given in first line setting. Unfortunately, what we see is that very often, and in Bulgaria, it's around 40% of the patients actually circulating free DNA is positive. In the other 60%, I know that the data is a little bit lower. The data for this mutation status is lower in Bulgaria. So for the other almost 2/3 of the patients, we need to make a new biopsy. And in my country, circulating free DNA is not a routine practice. And in melanoma setting, we don't have this opportunity to use it. Also in colorectal cancer. So we can use it only for the non-small cell lung cancer patients with EGFR mutations.
Thank you very much, Dr. Petrova. Now, to go to the last talk, Dr. Popovich.
I will talk about the session, where are we and where we are going in early breast cancer, better approaches to cure more patients. In her talk, Dr. Arnedas highlighted that endocrine therapy is backbone treatment for hormone receptor positive, HER2 negative early breast cancer. She discussed benefit of adding chemotherapy based on clinical pathological features and gene expression assays. She further discussed optimization of endocrine therapy and role of adding ovarian function suppression to adjuvant endocrine therapy for premenopausal women, role of extended duration of endocrine therapy, and combination of endocrine therapy with targeted therapy, reflecting on PALAS and monarchy and their different patient population, percentage of treatment discontinuation, and duration of follow-up. Finally, she highlighted the importance of adherence to therapy. Professor Bassaran in her talk talked about treatment tailoring in HER2-positive breast cancer, about escalation and de-escalation strategies in adjuvant and neoadjuvant setting. She discussed de-escalation strategies like short duration of anti-HER2 therapy, less chemotherapy, and chemotherapy-free strategies. From escalation strategy using 2 different anti-HER2 therapies, extended use of different anti-HER2 therapy, and tailoring therapy based on response, like in Kettering trial, post-neoadjuvant study for patients with residual disease, and per gain study, de-escalation to chemo-free therapy based on PET-CT response after 2 cycles of pertuzumab and trastuzumab. She highlighted the importance of better understanding of tumor biology and finding biomarkers. Finally, in his talk, Professor Schmidt discussed the benefit of chemotherapy in triple-negative breast cancer and potential de-escalation in T1N0 with high TILs. He discussed prognostic role of pathological complete response, role of post-neoadjuvant capecitabine for patients with residual disease, optimal chemotherapy regimen, and role of carboplatin addition to neoadjuvant chemotherapy. He highlighted that triple-negative breast cancer is very heterogeneous disease, and potential future therapies might be based on gene expression subtypes, like different immunotherapy strategies for basal immune activated or suppressed subtype, difficulties of targeting androgen receptor signaling in early settings, and future role of PARP inhibitors, ACT inhibitors, and antibody-drug conjugates. He then discussed immunotherapy in early triple-negative breast cancer, comparing Keynote 522 with recently presented Impassion 031, highlighting that these trials had different chemotherapy backbone with Keynote including platinum component, and that both PD-L1 positive and negative patients derived benefit from adding immunotherapy, unlike in metastatic setting. Greater benefit was observed in node positive compared with node negative patients in both trials. Very high PAT-CR rates were observed in patients with high CPS with more than 20 and more than 10. Although there is early EFS benefit in Keynote, there is need to further follow up for long-term benefit. He also highlighted several open questions in this field, like long-term benefit of immunotherapy, predictive role of PD-L1 positivity for long-term outcome, what is optimal chemotherapy backbone, what is contribution of adjuvant immunotherapy, and do we need it for patients who achieve PET-CR? What are the biomarkers for finding optimal responders, and can we salvage patients with residual disease using chemotherapy plus immunotherapy, antibody-drug conjugates alone, or in combination with immunotherapy? So currently, we are all going to be faced with diagnostic delay due to COVID pandemic, with more breast cancer diagnosed in more advanced stage. It's always important to highlight the importance of good multidisciplinary teamwork and appropriate management of these patients. In our region, we are often faced with availability issues like drug availability, availability of radiotherapy units, and availability of gene expression assays. We should encourage our patients to adhere to their adjuvant endocrine therapy and proactively manage side effects. And last but not least, we should enroll more patients in clinical trials to provide them with potentially better treatment options and increase their chances for cure.
Thank you, Dr. Popovich. Now, opening up the last question for the rest of the panel. With all we have learned from the ESMO 20 educational weekend regarding early breast cancer, how can you better treat patients in your countries? Dr. Popovich.
First of all, we need to establish in many of our countries screening programs. Still, we do not have a valid screening program in Serbia, and I know in many other countries we do not have very good screening programs. Second of all, availability of novel drugs is very important in metastatic breast cancer, but also in early breast cancer to cure more patients. We know from publication from Professor Vodolyak from Split that when your country invests more in health, your chance to survive cancer is higher. And we now are doing in our country negotiation to have pertuzumab in adjuvant setting in high-risk HER2-positive breast cancer. But next steps will be probably checkpoint inhibitors in neoadjuvant adjuvant treatment, abemaciclib in hormone receptor positive, and also some diagnostic tests like Oncotype, MammaPrint, or novel genomic tests to avoid chemotherapy when there is no need for it. So we need more investments from our countries in screening and novel drugs to cure more patients like in Western Europe and more developed countries.
Thank you very much, Dr. Popovich. Thank you all very much for joining and encouraging everyone to watch the presentations of the ESMO Educational Weekend found on Oncology Pro. Thanking everyone in our panel for their amazing insights, and we look forward to hosting you again.
Thank you so much.
Thank you.
Thank you.
Thank you, guys. Nice to see you at least.